Hi, this is Paul Workus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Welcome back to the Virtual Curbside. We're very fortunate to have Dr. Nicholas Whipple with us again this week. Thanks for braving another go at this. How you doing, Nicholas?
Doing well. Excited to be back. Thanks for having me again.
Good. So we've just come through a long COVID quarantine. That's to fix this in time. Did you develop any hobbies or obsessions during the quarantine?
I would say our family visited several national parks during quarantine, which we had never taken time to do before. And so Bryce Canyon, Canyonlands, we had never been to before, and we took our children to Arches for the first time. So short Utah trips. The Grand Tetons we went to, national park short trips, kind of a fun little hobby. We got very proficient at finding the best Airbnbs at the best price all around Utah and Wyoming.
Yeah, it's we really have an embarrassment of riches, don't we, in national parks. It's a wonderful thing. Well, terrific. Have you developed any conflicts of interest or anything you need to disclose since we last spoke?
I have not. Nothing to disclose.
Okay. Well, let's get started. So this week, I was hoping that we could talk about what I'm calling cancer therapies in a nutshell, because I think there are a couple that we're sort of acquainted with, and I want to touch on those. But there are several things that get talked about that someone like you, I think, has a much better idea about what these things mean and what the promises are and what the potential pitfalls are. So let's just dive right in. How does that sound?
Perfect.
It's a cancer therapy speed round. So I'll start the timer. So first thing is surgery, because we're talking about things that don't belong in your body. And so, what are the advantages of surgery?
Tumor debulking can significantly decrease morbidity and mortality. Cytoreduction has profound advantages regarding improving overall survival in most types of cancers.
And sometimes you get the whole thing, right?
Absolutely. I would say in general, that's always the goal, but cancer specific, there are definitely times where we intentionally do not get it all in order to not cause morbidity, because we know that our other therapies, which will be used, can take care of the rest.
So what are the downsides of surgery?
Morbidity, always. It's a possibility. Hospital stays can be lengthy, and it's always frustrating if you want to have something gross totally resected, but it can't be because of location or possible side effects. But in general, few downsides. In the hands of a skilled pediatric surgeon, things are going to go pretty well.
And are there surgical frontiers that you anticipate? Things that are new, novel surgical treatments?
Minimally invasive surgeries are becoming more and more common, even in cancer, meaning tumor debulking or removal laparoscopically. You can actually remove a complete spleen if you have to laparoscopically, and we're finding that with cancers. Yeah, absolutely.
Wow.
And many types of cancers we're able to do the same. Now, there are definitely many that you have to make wide incisions for and large incisions for, but minimally invasive surgeries would be one. Another in the space of central nervous system tumors, brain tumors, is laser interstitial thermal therapy, or LIT, which is basically a probe that is inserted into a tumor with heat applied in order to kill tumor cells. We're getting smarter and smarter at determining the right balance of upfront surgery versus giving chemotherapy followed by surgery. There are advantages to giving chemotherapy first. Sometimes it devascularizes tumors or shrinks tumors. Cancer specific though, many types you just have to do surgery first. Other types, we're learning we can give some chemotherapy and make the surgery less morbid.
Very interesting. Well, let's move on to chemotherapy. I think when we think about cancer, I think chemotherapy is almost always comes up in the conversation. What are the advantages of chemotherapy?
I like to think of chemotherapy as mopping up the non-visible tumor cells that are hiding or attempting to find safe harbor in some region of the body. but it can't be easily detected using imaging or other diagnostic measures. Statistically, we know that for a majority of diseases, chemotherapy is necessary, even if a tumor is completely surgically removed. This is because microscopic residual tumor or disease is virtually always left behind. When I started medical school, I asked one of my professors a very naive question. I said, will we ever be able to cure cancer? And his response was, well, every single type of cancer is completely different. And that's how I think about chemotherapy. What chemotherapies do we use? Well, you name the disease, and the chemotherapy regimen is different entirely than the one next door. We overlap with some of our chemotherapy medications, but we use them in a very cancer-specific way. And we've become very good at knowing which tumors absolutely need chemotherapy.
And some of that is because what seems to me to be an incredible ability among oncologists to collaborate in sharing information and coming up with approaches. Am I mistaken?
That's absolutely right. The Children's Oncology Group is the largest consortium that treats childhood cancer, and it has organizations and institutions all over the United States, Canada, Australia, and other places. And there are other groups for specific disease groups, central nervous system, sarcoma, and others. And it's the ability to treat children identically at multiple institutions that allows us to gain the knowledge we need to treat them better and with less toxicities.
What are the frontiers in chemotherapy?
I would say targeted and molecular-based chemotherapy are definitely on the frontier. Many times when we think of clinical trials, we think of someone who's going to be a guinea pig. We're going to try something new. And people are scared sometimes when they hear clinical trial. When I think of clinical trial, I think of we've taken everything we've ever learned about this disease and we've modified it in one or two small ways to try and either one, improve overall survival, or two, decrease toxicity of the way we currently treat it. And so frontiers of chemotherapy, I think, include decreasing certain types of chemotherapy and replacing it with other types of chemotherapy, such as molecular inhibitors. These have a role in almost every type of cancer and are becoming used with increasing frequency.
So what is a molecular therapy?
When I think of molecular therapy, I think of it as designed, intended, and used specifically for a particular genetic or molecular or immunologic target. For example, in my space or expertise of brain tumors, many tumors can have a mutation in the MAP kinase pathway. Specifically, they can have a BRAF V600E mutation. There are BRAF V600E inhibitors, and these medications are used to specifically target the defect in the tumor in order to turn off the light switch that the tumor turned on. Turning off that light switch helps the tumor to stop replicating and stop growing. It's different from a cytotoxic chemotherapy, because a cytotoxic chemotherapy is more of a bazooka approach, perhaps, where there may be more innocent bystanders who are affected, more innocent cells of the body that are affected with greater toxicities, whereas targeted therapy may be able to really solve certain problems in cancer because they harbor specific mutations.
And I suspect there are interests in that in every branch of oncology, that every tumor has something that you're trying to target.
I would say there's active clinical trials in that space for virtually every tumor, or active research for every tumor ongoing right now.
How about radiation therapy? What are the advantages of radiation therapy?
Radiation therapy has a fairly rapid onset. If there are certain solid tumors, which when they present, if there's a certain structure that's in immediate danger, a retinoblastoma that is imminently going to affect vision, a brain tumor that could imminently cause herniation. Radiation can have a very rapid onset and intense effect.
So what are the disadvantages?
Toxicities can be profound and very specific in radiation, just like chemotherapy. There can be radiation necrosis, which means death of normal tissue in the area receiving radiation, whether that's in the abdomen or the brain or the arm. Endocrinopathies, if you're radiating a thyroid or any hormone-producing gland or the pituitary gland, radiation can, with some degree of frequency, affect your endocrine axis. Cognitive impairment in young children who need radiation to the brain. Specific toxicities depending on the location of the tumor.
And what are there frontiers in radiation therapy in kids?
I would say yes, and I would say the most obvious one is proton radiation. So two main types of radiation delivery that we think about often in children would be photon and proton radiation. Any center that has radiation is going to have photons. Some centers have protons, and Utah, right now, June 2021, we are on the verge of opening our proton center here in Salt Lake. The difference between those are the following. If I have a weapon, a gun, and I load it with a photon, and I pull the trigger, that photon is going to enter, let's say it's a brain tumor. It's going to enter the side of the head. It's going to go to its destination, the brain tumor, and then it's going to exit the other side of the head. And it's going to pass through everything in between. The same holds true for the abdomen, the breast, anywhere that radiation is delivered. A proton, if I load a proton in a gun and pull the trigger, I can tell that proton where to stop. So that proton may enter one side of the head and then pass through the tumor, and I can tell that proton to stop on the other side of that tumor, so that all of the normal tissue on the opposite side of that tumor is spared and does not have toxicity. It's a very simplistic explanation. A radiation oncologist would be able to do it with even greater expertise. But proton radiation has the potential to decrease toxicity and long-term consequences like secondary malignancies. If I'm radiating a spine and I'm using protons, I can potentially spare the breast and thereby reducing one's risk of breast cancer later in life, or one's risk of colon cancer later in life, because that radiation does not reach those targets on the other side of your tumor.
So as with all the other therapies, it's the innocent bystander effect, trying to decrease the damage to the healthy areas.
Exactly.
Tell me about the role of stem cell and bone marrow transplants. Where does that fit in your world?
When I think of bone marrow transplants in oncology, I'm thinking almost exclusively of leukemia.
Mm-hmm.
Leukemia is a hematopoietic disease originating in the bone marrow. And children who have leukemia can be cured by traditional methods, but meaning chemotherapy, but children who are not cured with chemotherapy, or who do not respond appropriately or sufficiently, let's say, after the first couple of rounds of chemotherapy, we know through studies that they would benefit from a stem cell transplant, meaning taking their native bone marrow and replacing it with someone else's entirely in order to try and stomp out the leukemia process that started in the first place. So there are many other disease processes which can benefit from bone marrow transplant. Those are solid tumors. Two main types, I should say, of bone marrow transplants: allogeneic and autologous. Allogeneic is the situation where one individual receives a bone marrow transplant by receiving the bone marrow from a donor. That person's bone marrow is eradicated with chemotherapy and then replaced by a donor. That's the situation you use in leukemia, where you want to completely, entirely replace an individual's bone marrow. An autologous transplant is when you replace someone's bone marrow with their own bone marrow, which may sound a little counterintuitive, but there are some solid tumors, lymphomas, neuroblastomas, even some brain tumors in young children, which we give autologous bone marrow transplants for. And here's the reason. We collect that child's own native bone marrow, put it in the freezer and store it. And then we give that child very high doses, myeloablative doses, meaning essentially eliminating their own bone marrow, with the intent of that very high dose of chemotherapy is treating whatever tumor they have. And we're giving it in such high doses, we know that one of the side effects is going to be we wipe out their own bone marrow. And then we have to rescue their bone marrow by giving them back their own bone marrow that we've already taken and stored.
It seems to me that that the principles stay the same with that, but a lot of the increased success of bone marrow transplant has been that you've developed more sophisticated ways to take care of kids after a bone marrow transplant. Is that correct?
I would say that's absolutely true. Even though we are also better at producing a finer product, a cleaner product, a better matched product of bone marrow that we're giving to people, thus with a higher likelihood of successful engraftment, them accepting the bone marrow, the supportive measures that are given and available today, and the supportive medications, the wonderful ICUs, the ability to perform dialysis when needed, those supportive care measures have absolutely increased the effectiveness and decreased the toxicity of bone marrow transplants, with many of those underlying bone marrow transplant principles staying the same.
Big shout out to people who have dedicated a career to doing that very successfully. That's wonderful. Let's talk finally about immunotherapy, because it's interesting. I think we all have recognized in a lot of different diseases that our body has ways of getting rid of cells that we don't want to be there. And it seems like that's a growing interest in oncology as well. What sorts of things are happening with immunotherapy in oncology?
Great question. And it's a common question that we get from patients for virtually all types of cancer. What immunotherapy is available? When I think of immunotherapy, I describe it to patients as really being a type of cancer treatment that uses the patient's own immune system to fight cancer. So not just blasting away with chemotherapy, which is sometimes necessary, but trying to harness the body's own innate abilities to treat a specific type of cancer. Some of the immunotherapy frontiers, I would say, include, among others, chimeric antigen receptor T cells, or CAR T cell therapy. That is one of the therapies which is probably the most well-known or most talked about in pediatric cancer. It's a process where we harvest a child's T cells, a subset of their white blood cells, and process them in such a way that we train them and prepare them for a specific target in that child's body, whether that be leukemia or a CNS tumor or another tumor. So removing T cells, training them and giving them a specific target for that specific patient, and then releasing them back into the patient in order to attack that cancer in a new and different and smarter way. So CAR T cell therapy.
This sounds very Star Wars, training them to go after the Death Star.
I probably could come up with a perfect parallel for that from one of the Star Wars episodes. I'll have to think about that and get back to you.
I appreciate that. And where do we stand with that? Is that being used to treat some tumors?
It absolutely is. We use it here in Utah for hematopoietic diseases, for leukemias. We are using it around the country for other types of diseases, including central nervous system tumors. And I would say that it's being used with increasing frequency in many different types of cancers. But leukemia is really the one that helped us recognize its usefulness. So CAR T-cell therapy is one type of immunotherapy.
Monoclonal antibodies are being used to treat just about everything right now. Is there a role for that in oncology?
Absolutely. We use it all the time and for virtually all types of cancer. In the recent past, early 2000s, 2010s, it was being used almost exclusively in the recurrent setting. Phase 1 clinical trials where a tumor had recurred, had not responded to your first standard of care therapy, and you had to try something else, something new and different. As we've determined and identified the areas where it's most useful, it's now being incorporated more in upfront therapies and being added to the drug cocktail given for a specific type of cancer. It's infused very easily in an outpatient setting. In general, monoclonal antibodies are tolerated very, very well. And they play an important role and a growing role in both recurrent disease and pediatric cancer and in upfront disease.
I've read some about something called immune checkpoint inhibitors. Can you care to comment on that?
Sure. Checkpoint inhibitors are medications that are specifically designed to turn off the brakes on the immune system. So the immune system has certain signals or checkpoints that tell it when to slow down or when to speed up. And these checkpoints are important in order to get the right sort of response from your body to get out harmful things and to keep healthy things. Some cancer cells, some types of cancer will use these signals to hide from the immune system. And checkpoint inhibitors can turn off stop signals so that the immune system can keep going. Essentially, it turns on the light switch for your body's own immune system when the cancer has strategically turned off your body's immune system.
Very interesting. One other thing, I think as a pediatrician, I've said this on the podcast before. If the surgeon's slogan is a chance to cut is a chance to cure, I think the pediatrician's slogan is a chance to poke is a chance to prevent. I think we should be very clear about the fact that we do have at least one very good vaccine to help prevent cancer. That the HPV vaccine prevents cancer. It helps make it so that you don't need any of those therapies down the road. Are there other promising vaccines that you're aware of?
I completely agree with HPV, and we support it in our clinic at Primary Children's and actively encourage patients to obtain it. It's wonderful and much better to prevent a cancer than to treat a cancer. In terms of cancer vaccines, it's a very hot topic and one that is definitely present in the clinical trial space. There are right now cancer vaccines being given in clinical trials for multiple types of cancer. In general, for solid tumors being different from leukemias, which are liquid tumors, or lymphomas, which are liquid tumors. These vaccines have been very intelligently designed and are really just now being studied. And how effective are they? I would say the jury is still out and we don't know. My observation would be that it's probably not going to be a single use intervention, meaning that vaccines are going to have to be complemented with something else, say a cancer vaccine that's used to try and harness the body's immune system to attack tumor cells in a similar way that I just described for other therapies is going to have to be complemented still by other therapies like other chemotherapy and still having surgery and sometimes still having radiation. But it is another strategic way to try and help the body fight off cancer and should be studied. And I'm glad it's being studied, but it's still pretty early and tough to say how helpful it will or won't be. I'm sure we'll get smarter at using it and better at using it, and those vaccines will get better. We're really at the initial stages of cancer vaccines right now.
Any other therapies you want to comment on?
I would say the buzzword of targeted therapy, we've talked about it some when we talked about molecular therapy. Those terms are sometimes used interchangeably. Targeted therapy is what I think about when there's a specific mutation for which there is a specific medicine. That can be an infantile fibrosarcoma or a melanoma that has an NTRK mutation for which you can use an NTRK inhibitor. It can be a BRAF V600E mutation in CNS tumors, which we've previously discussed. These therapies we have found can absolutely put a patient into disease remission, meaning stop tumor growth or completely eliminate it from being visible on imaging when other therapies have failed to do so. What we aren't sure of is how long these targeted therapies will need to be used. Interestingly, in some types of cancer, when we use targeted therapies, we can use it for a certain period of time, 12 or 24 months, and then stop it. And then tumors can start to grow again. And we can restart the targeted therapy and again, stop the tumor. We're glad when we can do that, but it makes us a little nervous because we don't know how long we need to use it in the first place. And many cancers can become resistant to these targeted therapies by finding an escape mechanism. In other words, you turn off one light switch and the cancer can sometimes turn on another light switch somewhere else, and it becomes a game of whack-a-mole. And I say that term very respectfully, but that is what treatment of cancer sometimes feels like, using your toolbox and everything that's in it to try and beat that cancer. And when one tool doesn't work, you pull out the next tool, and trying to figure out the right combinations of tools at the right times and how many times you can use them and what the next tool is not an easy process. But that's why we're here as oncologists, and we're thankful that these new tools are becoming available.
And it's both encouraging and I think very heartening to see the horizon slowly but surely being moved back. Thanks so much for your expertise in treating our patients and also in educating about this. And of course, when people have questions, they could always touch base with your department and collaborate.
Absolutely. And you can call us anytime, and we are happy to discuss and happy to consult, and really enjoy collaborating with our colleagues in Utah.
Terrific.
And outside of Utah.
Well, terrific. Thanks again for spending some time with us the last couple of weeks. If people have questions, please direct your questions to questions@vcurb.com. And we'll look forward to talking again sometime in the future. Thank you, Dr. Whipple.
Thanks for having me.
Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Workus, who also composed the theme music. See you next time.